Welcome everyone. My name is Justin Koku. Thank you for joining me today for the second EKG video on variants and pathologies. In today's video, we are going to expand upon all that hard work we did in the first video, and we're going to look at when things don't quite look textbook. So we're going to start seeing when things can change a little bit, and when we should be concerned about that change. As an overview, this video has two parts. In the first one, we are going to discuss the normal variants that can be found on a 12 lead and how those changes can become pathological. In the first part of the video, we are not going to talk about why those changes are present. We're going to save that for the third video. We're just going to reassure ourselves that we have the tools necessary to be able to point out what is abnormal on a 12 lead. In the second part of this video, we are going to look at 10 examples. And I think by the time we get to the second part of this video, you're going to be surprised and hopefully happy with how much you can point out on a 12 lead. As a motivating example, if you had a patient and this was their 12 lead, what would you do? What would you say? If I asked you to point out the normal variance within this EKG versus the pathological findings in this EKG, would you be comfortable doing so? And I think you'll find by the end of this video, the answer to that question is yes. You will be very comfortable telling me what's a pathological finding versus what is a normal variant. So let's go ahead and get started. As always, we start with the P wave. Remember that the P wave is typically smooth in contour. It's typically upright, except in AVR and AVL, where it's typically negative. And in V1, where it's typically biphasic. And we know that it's not typically too big, so we do have some numbers. So it's typically less than 2.5 millimeters in the limbs and less than 1.5 in the precordials. As a normal variant, sometimes in V1 we'll see upright P waves. And that could be lead misplacement or just a normal variant for the person. There are a few things that we should keep an eye out for the P waves that may be associated with some pathologies. Now these, at least in pre-hospital medicine, where I spend most of my time, aren't necessarily too important, but they are good to be able to recognize, and that's peaked P waves. So we see here the P waves aren't smooth in contour, they're pointy. And here we have biphasic P waves, not in V1. And both of these findings represent just some atrial enlargement, so not typically too life-threatening. One P wave pathology that does come in handy with my field of work, and it is important to point out, are PR interval changes. So in this case, we have elevation. We see that P wave, and then the QRS complex, there's that elevation present. And then to the right, we have PR interval depression. Now it is worth pointing out that the PR interval elevation is concerning when it is in AVR, but the PR depression can be of concern throughout. That is to say, in all leads. So not too much to know for the P waves. Moving on to the Q wave. Remember that that's the negative deflection. Remember that small Q waves are okay, especially in the inferior leads. We know that V5 and V6 should have Q waves. And remember that AVR may have larger Q waves. And as some normal variants, I guess we could have put the AVR may have larger than 2 millimeters in Q wave, as in Q waves in the normal variant pile. But another normal variant is that those inferior leads don't have Q waves. And so here we see in lead 2, we have that P wave, we have the tiny Q wave, we have the R wave, and then we have the T wave. And that is reasonable because we said those inferior leads have small Q waves. Some pathologies associated with a Q wave. So if a Q wave is present and it's greater than 40 milliseconds wide, that is concerning. If it's greater than 2 millimeters deep, that is concerning. Again, that is not including AVR. If the QRS complex itself is small, but the Q wave is greater than 25% of the QRS complex, that is concerning. Q waves in V1 through V3 are not typical and should be concerning, as well as loss of Q waves in those lateral leads. And that is typically concerning. And so if we go over here to the example, we have in lead 2, we have that P wave. And here's this Q wave. And we said that the inferior leads should have Q waves, but notice that this Q wave is greater than 2 millimeters and greater than 25% the QRS height. So we call this a pathological Q wave. And we see the same story for lead 3. So there's our P, there's our Q, there's our R, there's our S, and there's our inverted T wave. And the same story for AVF. So we would say there are, in this case, there are inferior pathological Q waves. Next wave is the R wave. As a recap, we know it's the positive deflection. We remember that V1 through V6 pattern. So the V1 should have a small, if any, R wave, and then as we move to V6, we should have a dominant R wave. Some normal variants that we will encounter. On the left, we have that slight disruption to that V1 to V6 pattern. So we'll notice that in V1 we have no R wave. In V2, no R wave again. But this time in V3 we only have a very tiny R wave. But then we notice in V4 it almost is like it picks back up on the pattern. And then we start seeing dominant R wave, dominant R wave. This is a normal variant called poor R wave progression. And I call it a normal variant because it doesn't necessarily signify an acute process. And that's defined as a R wave in V3 less than 3 millimeters. And then on the right, we can see in this 12 lead, we have very dominant R waves in this V1, V2, V3. But in pediatrics, this is normal. So pediatrics have dominant V1 through V3 R waves. One of the pathological findings is when that occurs outside of being pediatric. So a dominant R wave in V1 in an adult is a pathological finding. And we see on the left we have that classic single pointy R wave, but on the right we have this R prime. And again, V1 really shouldn't have a dominant R wave. Another finding associated with the pathology is a dominant R wave in AVR. So here on the left we see we have that dominant positive deflection in AVR, so that dominant R wave. That is a pathological finding. And then on the right we see we have our P wave, we have the Q wave, and then here is our R wave. So we have that dominant R wave in AVR as well. And also we'll note that the R wave slurs into that T wave, which we call a terminal R wave. So notice how that R wave kind of just slumps into the T wave. That particular pattern is called the terminal R wave. Another pathological finding associated with the R wave is the delta wave. And it's that slurring. So here's a P wave. And it's that slurring of the R wave. The delta wave is typically associated with a short PR interval and a slightly widened QRS. But notice how that R wave slurs as it proceeds upwards. We call that a delta wave. Moving on to the S wave. And we know the S wave is that negative deflection. Now the S wave doesn't really become pathological in and of itself. And that's to say that the S wave will change if something else is going on, not necessarily change and indicate something in and of itself. Right? It's typically just an associated finding. But one of the pathological findings we associate with the S wave is slurred S wave. In here, so if we look at our 12 lead example on the right, if we notice that in 1, 2, V4, V5, V6, and AVL, that S wave, if we have our P wave, we have our R wave, the S wave comes down, and as it proceeds to the T wave, it kind of slurs. And that's called a S wave slurring or a slurred S wave. That's really the only thing to keep in mind for the S wave. Now we're going to move on to the J point and the ST segment. And remember that the ST segment is that space between the S and the T wave. Remember that the height is measured at the J point. And remember that the J point is that isoelectric point. And lastly, we remember that sometimes a J wave may be present. And just as a quick recap, remember that isoelectric point is right as we proceed down and things start to flatten out. Some normal variants we might find with the J point in the ST segment. The idea of this benign early repolarization. And benign early repolarization mimics ST elevation. So if we see here in lead 2, we have some elevation, lead 3 elevation, inferior leads elevation. A little bit of elevation in V2. Now, benign early repol, there are some things that we need to keep in mind if we look at a 12 lead and call something benign early repol. We need to keep in mind that it's common in African American males, or I should say it's common in African Americans. It's common in males. It's common less than 50 years old. It's uncommon if you're greater than 50, and it's rare if you're greater than 70. And another finding we typically find with Burr is the J wave. So if we look back at this 12 lead, and in the inferior leads, we see the J wave. V2, V3, we don't really see a J wave, but the presence of the J wave in the inferior leads, and if I told you that this was a 16-year-old male, we would all be pretty convinced that this was benign early repol. Now the story might change if I told you this was an 80-year-old female. Well, then we might need to investigate a little further. And that's because we're comfortable now with when benign early repol can pop up. One of the pathological findings of the J point is elevation. Remember, that's measured at the J point. And there are a lot of reasons why elevation may occur, but there are definitely numbers that we need to memorize if we're going to look at elevation and consider it a, say for instance, a STEMI, or if it's pathological. And we know that elevation is elevation when it's greater than or equal to 1 millimeters in all leads except V2 and V3. Now in leads V2 and V3, it gets broken up by gender and age. But thankfully just by gender for women. So in women, it needs to be greater than or equal to 1.5 millimeters in that V2, V3 leads to be considered STEMI criteria. In males, if you're less than 40 years old, we typically have stronger hearts, so we need 2.5 millimeters of elevation. If you're greater than 40, you typically need 2.0 millimeters of elevation. So if we go over to the example on the left, Here we have our baseline on the right. And where's our J point? Take a moment, pick out the J point. And if you said, well, here's our S wave, here's our T wave, and as my S wave moves up, it flattens out right here, so that's my J point, you would be correct. So then how many millimeters of elevation do we have? So we have about 1, 2, 3, 4. About 4 millimeters of elevation in this lead. How about the second one? You always draw that baseline. Here's the, let's say that's the J point. Let's say we have almost 2 millimeters of elevation. How about the third example? I would say here's the J point. Here's our baseline. So 1, 2, 3, 4, 5 millimeters of elevation. In this example, we see we have enough elevation. I would actually say the J point, you see right here, it flattens out just a little. So I'll erase that just to have another look. Let's zoom in. So we see that the wave comes up, and you see this flattening before it proceeds up. That would be the J point. Let's have another look at this one. We might as well keep zoomed in, right? So we have our baseline. We have that. The QS wave comes up. You see how we have this flattening. So that would be the J point. So then we would go down here. So it'd be 1, 2, 3, 4, 5, 6, 7 millimeters of elevation. Alright. Now, these numbers were for the standard 12 leads. That's the 12 lead that wraps around the left side of the chest to look at mainly the left side of the heart. Sometimes it's necessary to do right-sided 12 leads. And one of the voltage requirements that change in right-sided 12 leads is that we need in lead V4R to be greater than 1 millimeter of elevation. The other 12 lead that we can do is the posterior 12 lead. And in the posterior 12 lead, in leads V8 through V9, we need greater than 0.5 millimeters of elevation. So remember, when we look at a standard 12 lead, if there's elevation greater than 1 millimeter in any lead except for V2 through V3, I should say 2 congruent leads, right? Then that's concerning for pathological finding. In V2 through V3 specifically, if it's a woman, it needs to be greater than 1.5 millimeters. And if it's a male less than 40, it needs to be greater than 2.5 millimeters. Or if it's a male greater than 40, it needs to be greater than 2.0 millimeters. And then the right side and the posterior numbers we should have in the back of our mind as well. Another thing to keep in mind for elevation, however, is that there are multiple causes. And we're going to really dig in the next video. We're going to look at how to differentiate elevation through its different causes. So is it pericarditis? Is it left bundle branch block? Is it Brugada's? Is it STEMI? We'll look at that in the next video. Another J point in ST segment finding that is pathological is ST depression. And we'll see that there's 3 different types. So we have upsloping, downsloping, and horizontal. We should keep in mind that horizontal and downsloping are the more concerning of the two. And it becomes especially pathological if the depression at the J point, so remember all the ST depressions and elevations are measured at the J point, is greater than or equal to 0.5 millimeters in two greater than or equal to contiguous leads. So if we see depression and it looks like it slopes down or it's horizontal, the first thing we need to ask ourselves is this elsewhere? Do we see it in any other leads? And if we do, does it measure greater than 0.5 millimeters? And if the answer is yes, then we have a pathological finding that we need to investigate further. And so let's have a look at some examples. In the first one we have, let's zoom in. So we have that R wave, we have the S wave, and as the S wave comes up, we flatten. So there's that J point. And we see that this is a horizontal flattening. And so the next thing we want to know is, well, what does it measure at? Well, so here's our baseline. We see that that J point is about, I guess I should get rid of the line. It's about 2-ish. It's about 2 millimeters of ST depression. And it's horizontal. So that may be concerning. In the next example, here's our P wave, here's our R wave, here's our S wave. And as we come up and we flatten, so there's our J point. And we see that this time though we flatten down, so this is a downward slope. And we said that that itself can be a little concerning, so the next thing we want to know is the measure. So here's our baseline, here's our J point. We see it's about 1, 2, 3 millimeters of depression. So that may be concerning. In the next example, here again, here's our P, here's our R, here's our S. And as we come up and we flatten, so there's our J point, that isoelectric point, and we see that it is a downward ST depression. And the baseline seems to waver a bit, but if we take it as, say, right here, we say we have about 1 millimeter of downward sloping ST depression. In the next example, here's our downward S wave. Now, this is less of a J point as it is, I think, a fragmented or slurred S wave. So as we continue up and we flatten here, that is the true J point. And we see that this one is horizontal. And if this is our baseline, it's about 2 millimeters of ST depression, 2 millimeters of horizontal ST depression. If we go to our next example, here's our P wave, here's that R wave, here's that negative deflection, and we see here we flatten out. So there's our J point, and it looks to be a little downward sloping. And we have just about a little greater than 0.5 millimeters of downward sloping ST depression. In the last example, we have the tiny R wave, nice S wave, and as we come up and we flatten, it looks to be horizontal. So that flat is that J point. If we take this as our baseline, we have probably just about 0.5 millimeters of horizontal ST depression. Well, actually, this may be downward sloping, if this is the T wave right here. So we see how we can start to differentiate between the three types of ST depressions. And we'll remember that it's really that horizontal and that downward sloping that we really need to keep an eye at. Another change that is pathological within the ST segment community in the J point is reciprocal changes. Now, these are associated with ST elevation elsewhere. And a lot of times they're almost mirror images of the ST elevation. So we'll see here we have this pattern. We'll see that ST depression, that reciprocal change, is almost a mirror of that ST elevation. And that makes sense because the ST depression, or the reciprocal change, is looking at the same event, that infarct, but from the opposite side of the heart. So instead of having that elevation, you have the depression, but since it's the same event that's occurring both, they should look very similar. Alright. And that about does it for the J point and the ST segment. We're moving on to the T waves. We know that the T waves are typically upright. Except for in AVR, AVL, and V1. We know that they're typically less than 5 millimeters in the limb leads, and they're less than 10 millimeters in the precordial leads for men, less than 8 millimeters for women. Normal variance. You can have AVL inversion, V1 inversion, and in pediatrics, you can have V1 through V3 inversion of the T waves, which is just called juvenile T wave inversion. Let me see here, we have those nice inverted T waves in this 2-year-old's EKG. Now this T wave inversion in V1 through V3 can also be persistent, so we call that persistent juvenile T wave inversions. And this is most common in Afro-Caribbean women. So if we have a male from European descent and we see V1 through V3 T wave inversions, it would be relatively uncommon for him to have persistent juvenile T wave inversions. Now, some T waves can become pathological, and in this case we have peaked T waves, and those are described as tall, narrow, and symmetric. So if we look here at the example, here there's tall, narrow, symmetric. I was always taught that they look like T waves that you would not want to sit on. And then if we see what we mean by tall, if we go to the peak of the T wave and come down to the baseline, it's definitely greater than 10 millimeters, which is our upward max for the T waves. Keen eye would point out the J wave. Another pathological T wave finding are hyperacute T waves. These are described as asymmetrical and broad. So we see here this broad T wave, and it's asymmetrical. Hyperacute T waves can be present in something called loss of precordial T wave balance. And the idea is that if the T wave in V1 is greater than the T wave in V6, that is pathological. So if the T wave is broader, larger, and asymmetric, and it's bigger than the T wave in V6, we have a T wave pathological finding. And so we see here we have tall, that's greater than 10 millimeters, it's wide, and it's asymmetric. These are nice hyperacute T waves. Another pathological finding associated with T waves is inverted T waves. So again, outside of the juvenile T wave inversion or the persistent juvenile T wave inversion, we typically shouldn't have inverted T waves as we see here in the inferior leads and here in the lateral leads. Or I'm sorry, those are, V1, V2, V3, so the septal and anterior leads. And V1 we said can be inverted T waves, so we won't be too concerned with that. Another pathological T wave finding is biphasic P waves, or biphasic T waves. And we'll see that these come in two varieties, the up-down and the down-up. So we see we go up, then down, and down, then up. So biphasic T waves are something that is pathological. And lastly, for the T waves, we have De Winter's T waves. And these are a combination of two findings. The first is ST depression, and the second is hyperacute T waves. And so the classic De Winter's T wave is here in V4. So to zoom in, where we have our S wave. Here's our J point, that flattening out. And notice that the J point begins the slur upwards into the T wave. So we have both ST depression and this broad and asymmetrical T wave, and this hyperacute T wave. And that gives us our De Winter's T waves. And so if we go through, and one other thing, these are confined to the precordial leads. So V1 through V6. And if we go through, we see here we have a little bit of ST depression. Here's our flattening out J point. It's below our, it would help if I actually drew it, right? Our baseline. And we have this broad and asymmetric T wave. So we have a hyperacute T wave with ST depression. So we have a De Winter's T wave. More pronounced here in V3. There's our J point, so we have ST depression. We have that asymmetric broad and tall T wave to that hyperacute T wave, so we have a De Winter's T wave. And in fact, the pattern continues for V5 and V6. So we would say we have D winners, T waves, and V2 through V6. That's a pathological finding. And that about sums it up for the T waves and for part 1. So guys, that is a lot of stuff, a lot of things to keep in mind as we look at these 12 leads. It definitely takes practice, and I highly recommend looking at a lot of examples of EKGs to start to gain a familiarity with normal variance and when things don't look right. In the next section, we're going to do just that. We're going to look at 10 examples. But I think it would be a good idea to pause, go back over the notes, and gain some familiarity with these concepts prior to looking at these examples. Because for these examples, especially after the last 5, I would like to see you take charge and tell me what's wrong with the 12 leads. So, but if we're ready, let's move on to the examples. Alright, let's move on to the first example. Alright. So we remember from the first video that we have a quick 5 patterns that we can look at. That first pattern was that everything on the left side should be mostly positive deflections. And I say mostly because remember that lead 3 can sometimes have a dominant QS complex. But even barring that, we notice that there's definitely some T-wave inversions in the left side. So there's something wrong with this pattern. The second pattern was that AVR was all negative, so we had a negative P wave, a dominant QS complex, or at least a non-dominant R wave, and we had T wave inversions, and we see that our T waves are positive, so we see that that's false also. Our third pattern was that AVR and AVL were the only ones that had negative P waves and negative T waves, and we can quickly see that that's not true either. That fourth pattern was that switching of the R and S wave as we go from leads V1 to V6, and we see that that mostly holds up. That last pattern is that we don't have any major Q waves, and that mostly holds up as well. We see that initially these waves in V1 might look like Q waves, but we notice that we have tiny positive deflections. So these are really R, S, R prime complexes more than they are Q waves. In AVR, we see Q waves, but we remember that AVR is allowed to have some deep Q waves, although they are greater than 25% the QRS. So there's something we definitely want to keep an eye on. So we'll say for the fifth pattern, mostly. But we have 3 absolute things that are wrong with this pattern and 2 things that are kind of wrong with this pattern. So that tells us we need to look more closely at this 12 lead. So let's go ahead and do that. So we're just going to look at one lead at a time. So in V1 or in lead 1, we know that we should have a positive P wave, which we seem to have. We know that we should be predominantly positive deflections, so we should have a dominant R wave in lead 1. But here we see we have this RS complex, which is isoelectric. So that's something to keep in mind. But the one pathology that we definitely know we have is this T wave inversion. Alright, so we definitely have a pathological T-wave inversion in lead 1. Moving on to lead 2, we know we should have a positive P-wave. We know that if we do have tiny Q waves, which we do have, that's not concerning, it's a normal variant. We also know that those inferior leads sometimes don't have Q waves. We know we should have a dominant R wave, which we do, so in this case we have an RS complex. But this T wave inversion is definitely pathological again. Moving on to lead 3, we know we should have a positive P wave, which is a little hard to discern on this tracing. But if we see one right there, we see we have a little bit of an R prime complex, followed by a little S wave. But again, we have these T wave inversions, which are not normal. Moving on to AVR, we know we should have a negative P wave, which we have. Here we have a QR complex. And we know in AVR, the Q wave is allowed to be greater than 2 millimeters. But we haven't really talked about what happens when that Q wave is greater than 25% the R wave. So that might be something to look into. But the one pathology that we definitely know is wrong is that this T wave is supposed to be inverted. And it is, in fact, upright. AVR, typically inverted P wave, which is a little hard to discern. But it's mostly a negative complex, which we have with this QS complex. And we have inverted T waves, which we know to be fine as well in AVL. AVF. Here we see we have that positive P wave. We have an RS complex. Tiny Q waves. Sometimes not present really though, but that's fine, that's normal. And then here we see we have that inverted T wave, which is not particularly fine or normal. That is a pathological finding. Moving on to V1. We said V1 typically has biphasic P waves, which may be hard to discern, but it looks like a little biphasic. Looks like we have tiny R waves, so RS R prime complex, which is a little abnormal. And we said that V1 can have inverted T waves, but it's not uncommon to see upright T waves. V2, we see tiny R waves again. We see that positive P wave. So we have an R S R prime complex again, so R S R prime. And we know that the T wave should be upright, but it looks a little hard to discern. It looks like this is the T wave, so that's fine. In V3, here we have the P wave. We have an isoelectric RS complex, but which is expected. Remember, we said V3 or V4 could be isoelectric, and that means again that the R wave is the same height as the S wave. But here again, we have those inverted T waves, which are abnormal. In V4, here we have our P wave. It almost looks like we have some sloping, so we'll put question mark delta wave. We have an RS complex, which is reasonable. But here we have those inverted T waves. And these T wave inversions, if we look at the baseline, and go to the peak, is just about 10 millimeters. So 10 millimeters in the precordial leads for a male is right at the cusp of definitely being pathological, and it's 2 millimeters greater than what we would consider a pathological finding for a female. Moving on to V5, a little hard to find the P waves, wavering baseline, but we do see those little Q waves popping up, and that's what we should see. We see we have that dominant R complex, tiny S wave it seems, but the T wave inversions are very pronounced. Not quite as large as in V4, but still present. And there's no T wave inversions in V4 or V5, even though it's greater than 10 millimeters, that are normal variants. Here we have the P waves, we have the little Q waves, so we have a QR complex, which is standard for V6, and it looks like we have still these T wave inversions, although it's difficult to see with the wavering baseline. So there's a lot going on in this 12 lead. So we have lots of inverted T waves. We have maybe some delta wave. Maybe some pathological Q waves. Although I'd be a little less inclined for this one, because AVR is known for having deep Q waves. So quite a few things going on. And again, in this stage of the game, we don't necessarily need to put a name to what's going on. But now we know that if we were to take this patient to the hospital, we might want to get an attending and say, hey, come look at this for me. Right? Let's move on to example 2. We take a quick moment and go through the 5 patterns, and then go through each individual lead to see what you can find. Alright, so let's see. So pattern 1, we have that everything on the left side should be positive, mostly, asterisks, right? And we see that that's not strictly true because we have T wave inversions in lead 1, so not true. That second pattern is that AVR should be all negative. And for the most part, it seems to be true, except for we get to the P wave and we notice that the P wave is upright. So that's not true either. The third pattern is that AVR and AVL should really be the only ones with T wave inversions and negative P waves. But again, we see that that's not true because we have lead 1 and V2 have negative T waves. They're inverted T waves. V1 we see has inverted T waves, but not particularly concerning in and of itself. So we have not true. That fourth pattern was that V1 through V6 should wrap around. So we should have a dominant QS complex in V1 and then a dominant R wave in V6. And we see that that's not true because we have a very dominant R wave in V1, V2, V3. So the fourth pattern is not true either. And the fifth is that we have no pathological Q waves anywhere. And on first glance, that doesn't seem to be the case either. So we have Q waves in 1, 2, 3, and AVF. And we know that inferior Q waves are common, but they do look on the surface to be a little deeper than we would like. We do also have a little Q waves in V2, or V3 rather. So this isn't necessarily true either. So this quick glance at this 12 lead tells us we definitely need to take a closer look. Okay, so let's go ahead and do that now. Alright, let's look at V1. Lead 1. I always do that. We know lead 1 typically should have a positive P wave, but it seems here we have an inverted P wave. We know that not always, and it's not typical to have Q waves in lead 1. It's not part of that inferior view that is common to have Q waves. It's also, but it is a little bit of the high lateral view along with V5 and V6, which should have Q waves. But here we see, regardless, if we go to our baseline, whoops, it's really encroaching on that 2 millimeters of Q wave. So we'll say possible pathological Q wave in lead 1. Now this complex, this QRR prime complex, looks a little nasty. And we have some T wave inversions in lead 1 as well. Moving on to lead 2, we seem to have a biphasic P wave. We have another QRR prime complex, and this time that Q wave definitely looks to be greater than 2 millimeters. And it may even be greater than 25%. So we may have a pathological Q wave here in lead 2. And here it seems our T waves have flattened out. Or not flattened out, but come back to a positive deflection. In lead 3, it seems we have a kind of a fragmented P wave. And we're starting to get complexes, these KRS complexes that are just fragmented. Right? If we were to name this, this would be like a Q R S S prime, which isn't really a thing, right? So it would be a Q wave here, R wave here, S wave, deeper S wave. But these complicated QRS complexes we just call fragmented. And to kind of keep that in mind, when we look at this Q wave, that's definitely greater than 2 millimeters, and you know, if we ask, is it greater than 25% of the height of the QRS complex, that question becomes a little complicated to answer. So the Q wave, we'll say, is there. It's concerning, but it's kind of hard to figure out if it's a true pathological Q wave or if it's just a part of this grander fragmented QRS complex. Another thing that's interesting is we seem to have some ST elevation of about 1 millimeter. But keep in mind, I should have mentioned this earlier, this was one of my patients. He's 17 and African American and a male. So benign early repole is very likely for this elevation and this somewhat hyperacute T wave. But even if we look at the criteria, so we know that, so how big should the T waves be in the limb leads? If you said 5 millimeters, you are correct. So it is a little greater than 5 millimeters. But again, the whole QRS complex is a little messy, so we'll call it benign early repole. Moving to AVR, we know that the P wave should be negative, but it seems to be positive, if not a little biphasic here. Again, we have this RS complex, and it seems like this S wave is fragmented or even slurred. And the T waves are fine because we know the T wave should be inverted. In AVL, we should have inverted P waves, which we do. We're kind of moving back to this fragmented QRS complex, this RS, R prime, R double prime complex. In AVL, we know the T wave should be inverted, so that's fine. AVF, the P wave definitely seems to be a little biphasic in this inferior lead. We have this fragmented QRS again. we have a little bit of benign early repole, and our T waves are upright as we would expect them to be. In V1, again we look at the P wave. We have biphasic P wave, so P wave is a check. We kind of have this messy QRS complex again. Maybe a little ST depression. And we know that the T wave is okay being inverted in V1. In V2, we have upright P waves. We have this messy, fragmented QRS complex again. But these T wave inversions are definitely not normal. Here in V3, we have our P waves are upright. Here we have a slightly less messy QRS complex, but still pretty messy, right? We have a Q wave, R wave, S prime. Maybe a little bit of benign early repole action. And we have an upright T wave as we would expect. Moving on to V4. I'm going to get rid of some of this. In V4, we have this upright P wave. We have this messy QRS fragment again. And this time we have some elevation that we're going to again call burr. V5, similar story. We have P waves, we have messy fragment. We definitely have some elevation. And we have some pretty tall T waves. And these lateral leads definitely have some tall T waves. And the same story in V6. So here's our P wave, our messy QRS complex, our elevation, and we'll say these tall T waves. So quite a bit going on for a 17-year-old male who called 911 for syncope. So what do we have all in all? Well, we have lots of messy QRS complex. We have a good bit of T-wave inversions. We have a good bit of tall T-waves. A good bit of benign early repole. So there seems to be a lot going on with the 17-year-old. And some S-wave slurring. Alright, so that was a pretty messy example, right? Hopefully example 3 is a little more straightforward. Oh, this should look familiar. So let's take a moment, pause the video, go through the 5 patterns that we've talked about, and then go through each lead and start pointing out the things that are wrong. And both, classify it as, is it a normal variant or is it a pathological finding? And I'll see you back when you're done. Alright, welcome back, guys. So let's go through those quick 5 patterns. That first one is that everything on the left side should mostly be positive. And we see that that's not entirely true because we have some T-wave inversions in lead 3. That second pattern, that AVR is all negative. And we see that that's mostly true. We have a negative P wave, we have a dominant Q wave, and we have a negative T wave. Lead 3 was that AVR and AVL should really be the only negative T waves and negative P waves. And we see that, well, AVL doesn't have negative T waves, which is a normal finding. But we see V2 has some inverted T waves, so not quite. As well as lead 3, right? The fourth pattern was that the V1 through V6 pattern. And we see that's not quite true because V1, V2, and V3 all have some pretty dominant R waves. So not quite. In that fifth pattern, that we don't have any pathological Q waves anywhere, any Q waves poking their head out. And that seems to be true. But there are some things wrong with this quick 5 pattern. And so when we look at each individual 12 lead, or each individual lead in the 12 lead, hopefully we can start to discern some more findings. Let's go to V1. What do we have? Lead 1. Okay. So we know lead 1 should have some positive P wave activity, which it seems to. We see a little Q wave action, but it neither seems to be greater than 40 milliseconds, greater than 2 millimeters, or greater than 25% the preceding height, and it is not in V1 or V1, 2, or 3. So that's a variant Q wave. We have a R wave. We have this S wave, and notice that this S wave looks to be, I'm going to change, hold on, so we have a variant Q wave, and we have S slurring. So that S wave kind of slurs as it moves up. But other than that, we're pretty good. We have no elevation, no depression at the J point, our T wave is positive. So in lead 1, we just have a normal variant Q wave and some S wave slurring. In lead 2, we have that positive P wave. We have a dominant R wave. We have a little bit of slurring S wave. On the eye, it looks like we may have ever so slight ST depression. But our T wave is upright, and that's exactly how it should be. In lead 3, we know that the P wave should be upright, but it seems that we have a biphasic P wave. Right. We know that lead 3 can be a predominantly negative deflection. That's not too concerning. But the QRS complex looks relatively fine. There's no ST elevation or depression in the J point. But what is slightly concerning is this inverted T wave. Alright, moving on. In AVR, we see we have the inverted P wave, dominant Q wave, so we have a QR complex, which is fine. Doesn't seem to be any ST elevation or depression. And we have an inverted T wave, which is fine. In AVL, we have a upright P wave, which is fine. We know sometimes and typically it's negative. We do have little Q waves present, but they seem to be neither 2 millimeters, 40 milliseconds, or greater than 25% the QRS complex, and they're also not in V1 through V3. So we'll say that we just have a variant Q. We do have some S wave slurring right here. There doesn't seem to be any elevation or depression of the ST segments, and the T wave is upright as we would expect it to be. In AVF, we know that upright P wave is the norm, but it seems we have some biphasic P waves. The QRS complex is isoelectric, which is fine. And we have upright T waves as it should be. So not too much going on in AVF. In V1, we have some interesting P waves. They almost look squished. And they're upright. It seems that maybe we have some PR depression, so some of that PR interval depression. This complex seems to be an RSR prime complex, so RSR prime complex. That S should be small. There doesn't seem to be any ST segment elevation or depression. And we know that inverted T waves in V1 is relatively fine. Moving on to V2, we have this upright P wave. Again, we have this RSR prime complex. This time we seem to have, so we have both PR depression as well as we seem to have ST depression, and it seems to be down sloping. So that means we're concerned with the amount. So if we go to our baseline, and here's our J point, seems to be just about 2 millimeters. But it seems that our T wave is upright as we would want it to be. So then we have to keep in mind, we have to look at V3 to see if there's also ST depression. So when we look at the P wave in V3 and it's upright, we do seem to have some PR depression. We have a RSR prime complex. And it seems that if we draw a baseline, we do have some ST depression. So now we have a little bit of pathologic ST depression. But our T wave is upright as we would want it to be. Moving on to V4, we see we have our P wave. Let's see. If we have, so we have a little bit, not too much to write home about, but a little bit of PR depression. We have a nice RS complex with some slurred S wave. It also seems like our ST depression is relieving, but we'll say a little bit of it is still there. And our T wave is upright, which is how we would want it to be. Moving on to V6 or V5, we have that positive P wave, we have that little Q wave, which should be present in V5. We have this RS complex with a little bit of S wave slurring. Our S wave, both our PR depression and our ST depression have seemed to alleviate it. And we have an upright T wave. V6, we have a P wave, we have our tiny Q wave, we have that RS complex, we have a little bit of that S slurring. No apparent ST depression or elevation, and our T wave is upright as we would want it to be. Alright, not too shabby. Not too shabby. So all in all, we seem to have some S wave slurring. We have lots of kind of R prime style complexes. Do we have some PR depression? Do we have some ST depression? So quite a bit going on in this 12 lead. let's move on to the next one. So as always, take a moment, go through the 5 pattern, and then go through each lead and see what you can find. Alright, welcome back. So let's go through the first pattern. We have where everything on the left side is positive, and that seems to be true. The second pattern where AVR is all negative, and that seems to be true. The third pattern where AVR and AVL are the only ones with negative P's and negative T's, and that seems to be true. The fourth pattern where we have that progression from V1 to V6, and that seems to be true. And that fifth pattern where there's no crazy Q waves jumping out at us anywhere, and that seems to be true. Interesting. So there seems to be everything is correct with this 12 lead. Well, just for the sake of completion, let's go through and look at each lead individually. So we know we should have upright P wave, which we do. We should know we should have a predominantly positive deflection in lead 1. So in this case, we do have an RS complex, which is predominantly positive, and we know we have upright T waves. And we don't have any ST elevation or ST depression, and we don't have any crazy nonsense going on with slurring of the S wave or slurring of the R wave. So lead 1 looks healthy. Lead 2, we know we should have upright P waves. We have little Q waves, which we said are normal in the inferior leads. And just to be sure, we know that they're not greater than 2 millimeters, greater than 40 milliseconds, or greater than 25% of the height of the R wave. In this case, we have a QR complex. One might argue if, not really. And we have T waves upright as they should be. In the inferior lead, of lead 3, we have that positive P wave, those tiny Q waves, so we have that QR complex. And it does look like we're getting some elevation, but there's nothing to write home about. And it seems that we do have this J wave, which gives an argument for benign early repole. Moving on to AVR, we know AVR should be backwards everything, reversed. So we have an inverted P wave, we have that predominantly negative QS complex, and we should have an inverted T wave, which is what we have. And no apparent ST elevation or ST depression or anything else. Here we have the P wave, here we have an RS complex, so AVL typically predominantly negative. And the T wave's pretty flattened, so nothing to write home about there. AVF, we have positive P wave, small Q wave, typical for the inferior leads. We have that QR complex, a little bit of elevation. But here I think you can see a little hard, but the J wave. That little bump. V1, we have a biphasic P wave. That looks good. We have a dominant S wave. We have a RS complex. And the T wave is inverted, which is fine. And no apparent ST elevation or ST depression. Here we have positive P wave. We have an RS complex still, although the R wave does seem to be bigger than in V1. Maybe a little bit of ST elevation, but since we saw that J wave and it looked like burr before, it's probably burr now. And we see that our T waves are upright as they should be. Moving to V3, we see now we definitely have a predominant R wave, almost isoelectric. We have a positive P wave, a little bit of ST depression, or elevation rather, so that J point right there. and we have some positive T waves. In V4, we have that P wave. We have no Q waves. We have a dominant R wave. So this one's definitely an RS complex. And we could say that's a little bit of elevation, and our T waves are upright as they should be. V5, we have upright P waves. We have those tiny Q waves. We have a QR complex. A little bit of elevation, and we have good T waves. V6, again, we have that positive P wave. We have those tiny Q waves, so we have a QR complex. ST elevation looks good. And we have positive T waves as we would expect. So all in all, this looks like a relatively uneventful EKG, right? The most we found was some benign early repull. Not too shabby. Alright. Moving on to the next example. This one, I really would like you to take a moment, whether it's 10, 15 minutes, or however long it takes, and go through this 12 lead and see what you can find. Alright. So why don't you go ahead and pause the video. Here, if you want to pause the video, I'll zoom it in. And I'll see you guys when you finish. Alright, welcome back, guys. So same as usual, let's go through those quick 5 patterns, see what we have. And pattern 1, we have that everything on the left side should be predominantly positive. And we see that this is violated with, there's T waves. Looks almost biphasic T waves, so not really. That pattern 2 is that AVR is predominantly negative, and we see that negative P wave, negative RS complex, and negative T waves. That's true. The third pattern is that AVR and AVL should be only negative P's and negative T's around, notwithstanding V1. And we see that that's mostly true. AVL has positive T's, which AVL kind of just does whatever it wants in terms of the T waves, so we'll say that's true. P4 is that wraparound from V1 to V6. And then we see the little r, big R, big R, big R, big R, big R. So yep, that seems to be true. And P5 is that we don't have any crazy Q waves sticking out at us. Well, we do see some Q waves here, Q waves here, Q waves here, Q waves here, and Q waves here. Little Q waves there, and we know that Q waves in V1 through V3 are definitely not okay, so that one's going to be a no. Alright, since we have some things wrong with this quick 5 pattern, let's go ahead and look at each lead individually. Alrighty. So in lead 1, we see we have a positive P wave, which is good. Is what we would expect. We do have a tiny Q wave, so this would be a QRS complex. And notice I made the R wave capital. But if we were to look at this Q wave, you know, we're looking at greater than 2 millimeters, 25% the R wave, V1 through V3. It doesn't really meet any pathologic criteria. There doesn't seem to be any ST elevation. Oh, maybe. Yep, a little bit of ST depression. About 1 millimeter. So remember, we come up, and that flattening is that J point. And we have a positive T wave as we would expect. So I'm going to erase everything other than the stuff that is abnormal. So in lead 1, we have ST depression about 1 millimeter, and it's horizontal. In lead 2, we have positive P waves. We definitely have this Q wave here. And let's see what it's doing. It's 1, 2, 3 millimeters. So we definitely have a pathologic Q wave. We have an R complex. And we have this little odd terminal slurring. That's R wave terminal slurring. And almost a little bit of a biphasic P wave, which is probably the beginnings of ST depression. But in this complex alone, we'll just say pathologic Q wave in lead 2. Although we're definitely going to keep an eye on that ST segment. In lead 3, we seem to have a P wave, that's good. We have a Q wave that's less than 2 millimeters. But here, so that's not anything to write home about, and we have a QR complex, but here we notice two things. One, this J point, so we have about 1 millimeter of ST elevation. And we have a little bit of a biphasic T wave, right? Because if we come, here's our J point, and then we proceed down and then come up, and then we go like this again. So we have a down up biphasic T wave. So we have some ST elevation and a biphasic T wave. Coming up to AVR, we have that negative P wave. We have that little R wave, so that RS complex, and we have the inverted T waves. So we see that everything in AVR is good. In AVL, we have that P wave. We have this slurring, this R wave, so RS complex. But notice it looks like we have some ST depression. So let's get rid of the normal stuff. So we have horizontal ST depression. And let's see how much it is depressed. So we come up, flat, so there's our J point. Let's find our baseline. So about 1 millimeter of ST depression. Now remember, our ST depression was greater than or equal to 0.5 millimeters of depression in 2 or more contiguous leads. So that can be a little concerning. So this high lateral lead has some ST depression, and we noticed lead 1 also had a little bit of ST depression, and those are contiguous leads. So we definitely have pathologic ST depression happening now. In AVF, we have this P wave, we have this 2 millimeter Q wave, right? And we said Q waves are common in the inferior leads, and it is just at 2 millimeters, so we're going to keep an eye on it. We have a QR complex, and if we look at our baseline, we do have some ST elevation. Of about 1 millimeter. And again, we kind of have that down up T wave, that biphasic down up T wave. Moving over to V1, we have our biphasic P wave. We have the RS complex. Doesn't seem to be any, doesn't seem to be any ST elevation, and we have the upright T wave as we would expect. So V1 is relatively healthy. V2, we have this upright P wave. We have this almost isoelectric RS complex. But notice we definitely have some ST depression. It's upward. And this kind of looks a little bit like a hyperacute T wave. And in fact, the first thing we want to ask ourselves when we see a hyperacute T wave in V1, 2, or 3 is if we have loss of appropriate precordial T wave. And so we look over here and we see in V6, our T waves are much smaller than in V2. So that supports our argument that we have hyperacute T waves. So now we're in a situation where we have both ST depression and hyperacute T waves, and we're in the precordial leads. So this is a good argument for D winners T waves. And we'll say the loss. Moving on to V3. We do have some Q waves, so pathologic Q waves. Because remember we said in V1, V2, V3, we definitely shouldn't have Q waves. We have a QRS complex. We have ST depression. And then, again, very similar to the D winners T wave pattern, right? So we have that ST depression with that upward sloping into the T wave. The T wave itself looks pretty bigger than it should, especially when comparing it to the V6 T wave. So a pretty good argument for that D winners T wave. Moving over to V4. Now V4 in and of itself having Q waves isn't anything in particular, except for if it meets that other pathologic criteria of greater than 2 millimeters, greater than 40 milliseconds, greater than 25% the height of the QRS complex, and 1, 2, and it seems to be right about 3 millimeters, so I would be pretty comfortable saying that this also has some pathologic Q waves. We have a QRS complex. The baseline is a little wavery, because if we start out here, I guess it's reasonable that we have some ST depression of about 1 millimeter horizontal. And again, we kind of have the same pattern of ST depression, slightly hyperacute T wave, so we'll say D winners. For V5, we have that Q wave. Now remember, V5 and V6 should have tiny Q waves. So they're definitely bigger than tiny, and they are also about 3 milliliters, so we'll say some pathological Q waves. Let's erase some of this and erase some of the noise. So in terms of ST elevation or ST depression, it seems that has resolved itself. If not, maybe a little bit of ST elevation. And our T waves are upright as we would want them to be. So pathological Q waves and a little bit of ST elevation, it seems. But it's a little hard because the baseline is, and that looks a little bit like a J wave. So we'll definitely keep that question mark there. But we move on to V6, and we see we have P wave, good. Q wave, a little bigger than we would like. Let's look at that ST, because right off the bat you see some ST elevation, so let's find our baseline. And that looks like a J wave. So again, we'll say pathologic Q wave. Question mark ST elevation. It definitely looks slurry, right? And our T waves are upright as they should be. So all in all, we have some interesting findings. So we have some pathologic ST depression in the high laterals. If I could spell high. So that lead 1 in AVL. We have some biphasic T's in the inferior. D winners T waves are present. Question mark ST elevation in the lateral leads. Right. So definitely some things going on, and also some path Q waves. So there's definitely some things going on in this 12 lead that need to be investigated. Good job, good job. So let's move on to the next one. Lead 6, or example 6 rather. Same as before, I'm going to zoom in for you. If you guys want to go through the 5 patterns and then go through each lead to see what you find, and then come back to me, that would be great. Alright guys, good luck. Alright guys, welcome back. So let's go through that 5 pattern again. So pattern 1, we have that left side is mostly negative, and right away we see in lead 2 that that's not the case. So nope. Pattern 2 was that AVR is mostly negative, and we see that we have our R wave is bigger than our Q wave, so that's going to be a nope as well. Pattern 3 is that AVL negative P negative T, and that should really be the only one that does that, along with AVR. And we see that, well, for what it's worth, that's mostly true. Pattern 4, we have that shifting from V1 to V6, and we see that that is not really true because we lack R waves really in these lateral leads. So not really. And that 5th is that we don't have any pathologic Q waves anywhere. And so let's see, let's go through. Now V3 may look like Q waves, but there is that tiny positive deflection prior to that downward, so that makes me think that this is a massive RS complex. AVR has some Q waves, but again, that's normal. These look like QS complexes. These have definitely little R waves. These definitely look like little R waves. These are fragmented. So I would say, actually, in terms of the Q waves, we are good. But we still have some things wrong. Some things popped up in our quick little analysis. So let's go and dive a little deeper and see what we find. So as usual, we go to lead 1. And we know we should have an upright P wave, which we do. It looks like we have a little slurring. So we'll say like question delta wave. But notice we definitely seem to have some ST depression. Right. So we come up, here's our J point, and so it comes down after that. So that looks like down ST depression. And we're looking at about 2 millimeters. And we have a, just for sake of completion, so this is a RS wave. But as before, we're only going to keep the things that are wrong. So maybe a little bit of a delta wave, but we definitely have some ST depression that's downward sloping, and it looks to be about 2 millimeters. And it looks like our T wave is upright how we would want it to be. In lead 2, we have a positive P wave. Looks like we have a RS complex. But again, it looks like we have some ST depression. And it looks to be about 2 millimeters again. So there's our J point. So we have horizontal 2 millimeter ST depression in lead 2. And we have upright T waves, which we would expect. So perfect. Moving on to lead 3. It looks like we have, so let's start at the P wave as always. We have P wave. It looks like we have a tiny R wave. It looks like we come up. So it looks like we have a SR prime complex. Let's get rid of that. But then we see as it comes down, we flatten out. So we definitely have that's not the baseline. Sometimes the baseline can be a little harder than the J point, right? As we come from P to P. So maybe a little bit of ST elevation. It would be about 1 millimeter. Okay. And our T wave is upright, which is what we would want. AVR. You know AVR should be backwards, so we have that inverted P wave. We have this broad Q wave, so greater than 40 milliseconds. Put path of Q wave. But as we come up to the R wave, who knows, we definitely have we have two things going on here. We have a dominant R wave, which we said in AVR was atypical. And that dominant R wave kind of slurs down into the T wave. And there looks to be a little bit like 2 millimeter of ST elevation. So we have both a dominant R wave, some apparent ST elevation, and looks like a little bit of a pathologic Q wave. So definitely some stuff going on in AVR. If we come up to AVL, we have that P wave, we have the RS. Let's see, do we have, there's a baseline. Baseline. So it does look like, so we have some S wave slurring. We also seem to have some ST depression, which is down. So we have down ST depression, and it looks like it's about 1 millimeter. Interesting. Let's move on to V1. We know V1 should have a biphasic P wave, and it's mostly biphasic. Right. We have what looks to be a tiny R wave, dominant S wave. So that's all normal. But if we draw our baseline, looks like we have about 2 millimeters of ST elevation present. And our T wave is upright, which isn't too concerning in V1. Moving to V2, we have that dominant P, or the upright P, tiny R, dominant S, and then the question becomes, do we have any ST elevation? Which again is a little difficult, but maybe 0.5 millimeters of ST elevation. And we have upright T waves, which is what we would expect. Then remember in V2, V3, we have different ST elevation requirements for when it becomes kind of pathologic, especially for a STEMI. And since we don't know if this is a male or female, it's a little difficult to say. In V3, we have that upright P wave, tiny R wave, and that R wave is definitely meets criteria for the poor R wave progression. We have a dominant S wave, and we come up and we have this isoelectric point, so that's our J point, and it would seem like we have so it's upward sloping, ST depression, and it's about, let's take a look, 2 millimeters. Remember, we said upward was the better of the two, or the better of the three. So we said that horizontal, that downward sloping, that's really when we wanted to look at how much depression was actually going on. But this looks like it's upward ST depression at 2 millimeters, along with that poor R wave progression. V4, we have the P wave. We have this tiny R wave. Remember, V4 should have some pretty pronounced R waves. So this is atypical in and of itself. Although there is no poor R wave progression in V4, we will say question mark, where's the R wave? We have this dominant S wave with this J point. And we see that we have some J point depression on the order of 1, 2, about 2 millimeters again. ST depression, 2 millimeters. And I would say that that's upward sloping again. And also just bear in mind that this QRS complex is encroaching on a little widened. Right? V5, we have that upwards P. We have this R wave with this very fragmented S. Seems like we have some horizontal ST depression. 1, 2, about 3 millimeters. I wrote 2 again. And our T waves are upright, how we would want. We'll keep the R on fragmented S and what looks like to be a little bit of ST depression. In V6, we have that P wave. Again, we have this R with the fragmented S. Definitely have some ST depression, about 4 millimeters. I would say that's horizontal. So now we have 2 horizontal ST depressions greater than 0.5 millimeters. So now we have pathologic ST depression in the lateral leads. And our T wave is upright how we would want. So we have that ST depression and that R fragmented S. So quite a bit going on. Quite a bit. All in all, we seem to have a lot of ST depression, especially in the high laterals. So 1 AVL, they're contiguous leads, and the laterals, so V5 and V6. So that's pathologic finding. We seem to have poor R wave progression. Seems that we have some ST elevation in V1 and V2, although they don't quite meet criteria. A little bit in lead 3, it seems. So quite a lot going on with the ST segments in this 12 lead. Good job. Moving right along to the 7th example. Do your thing, guys. So go through the 5 pattern and then go through each lead and then join me when you're ready. Alright guys, welcome back. So as before, we will go through the first pattern, and that's everything on the left side is predominantly negative or positive, and we see that that's true. Lead 3 is negative, but we said that lead 3 being negative is a common variant, so we'll say true for the first. The second one is that AVR is mostly all negative. And we see we have a negative P, a dominant Q, and a negative T. This is true. P3 is that AVL-AVR relationship, and we see that that's not quite true because we said AVL, if it has a negative or inverted T wave, will be the only one besides V1 and AVR, and we see that's not true. P4 is that wraparound from V1 to V6, and we see that that's true. And that fifth one is that we don't have any crazy Q waves poking out at us, and besides AVR, which has its standard Q wave action, that's true. But if we notice as we're looking at these Q waves, where are the Q waves? That's the question, isn't it? So P5 is not really. So we definitely have some things to look over as we proceed. So as always, let's go to the first lead. And this time I'm only going to write and point out things as we find them. I'm going to pick up the pace a little bit as if we were really analyzing these 12 leads. So I see upright P waves, I see a little bit of S slurring, I see an RS complex, and I see a positive T wave, so we're good. Lead 2, positive P wave, I see a RS complex, a little bit of S slurring, maybe a little bit of ST depression, it's horizontal, it's about 1 millimeter, and my T wave is good. Lead 3, I see a positive P, I see an RS complex, no ST, and I see a positive T, so I'm good. AVR, we should see a negative P wave, we see a dominant RQR complex. However, if we look, there seems to be some subtle ST elevation in AVR. And we're going to say that it's about 1 millimeter-ish. Here's the J point. Alright, so ST elevation in AVR. AVL, we have no discernible P waves, not too concerning. We have a dominant R wave with a little S complex, not too concerning. T waves, not too concerning. AVL really isn't a concerning lead. P waves, good. QS with a little bit of S slurring. Do we have a little bit of ST depression? That's the question. So we'll find our baseline. And it seems that we do have some ST depression. It seems to be horizontal, and it seems to be about, it's always hard to tell when you're drawing over it. But if we just go here, almost about, we'll say 2 millimeters. Going up to V1, we have biphasic P waves, tiny R waves, S wave, and then we seem to have 2 millimeters of ST elevation, and maybe even redraw our baseline. So down up biphasic T. So 2 millimeters of elevation there. Lead 2, positive P, we have an R wave, dominant S wave, we go back up quite a bit, and now we have 3 millimeters of ST elevation. So we now have pathologic ST elevation in greater than 2 contiguous leads. We have P, R, S, 1 millimeter of ST elevation, so that makes 3 contiguous leads. Remember V3. Well, I guess we need to know the sex and the age. for V2 and V3. V4, we have a P wave, dominant R, isoelectric almost. No real concernable ST depressions or elevations. And our T wave is positive. P wave is present, absent Qs. That's pathologic in V5, V6. We have some S wave slurring. And if we draw a baseline, we have a little bit of ST depression in the lateral lead V5. Again, we have P wave, little tiny Q wave here in V5 or V6, dominant R wave, a little bit of S slurring. Sorry if I could spell. And if we draw a little bit of ST depression, it seems to be horizontal. So, a little quicker to go through these. So we can see that this method is great for practice, but can also be adopted to be a little quicker for looking at real 12 leads. But so all in all, we seem to have some contiguous ST elevation, some contiguous ST depressions, right, and some S wave slurring throughout. Interesting. All right. Another example, you guys do your thing, the patterns, and then go through each lead, and I'll see you when we get back. All right, welcome back. So let's go through this even a little bit quicker than we did before. So looking at the left side, we see something's wrong because lead 1, it has a dominant S wave. In AVR, we see that things are mostly negative, although the P wave is hard to discern. We see that AVL has a positive T wave, which isn't too concerning, but it does seem to be the only other one with a, so no other ones besides V1 has a negative T wave, so we're good. V1 to V6 pattern seems to be intact, and lastly we look at the Q waves, and we see that we do have some Q waves in V1, which is concerning. We do have some baby Q waves in the inferior leads, which is not too concerning, but this tells us we should look a little further, because as we were perusing this 12 lead, things just were hopefully not looking normal, right? So in V1, we have this slightly widened QRS. We have this parent ST elevation, right? And our T wave is positive. We have in lead 2, positive P wave, tiny Q wave. We have this odd slurring of the terminal R wave, right? And a positive T wave. In lead 3, we definitely have some ST depression. We have baby Q wave, positive P wave. We have this widened kind of slurry R wave, or QRS complex. In AVR, we have a predominantly negative, so everything is good there. In AVL, we have a tiny R wave, kind of a widened S wave. And we seem to have some ST elevation in lead AVL. So we have 2 contiguous leads with ST elevation, so that is concerning. In AVF, we have tiny Q wave. We seem to have a little bit of ST depression. So we have 2 ST depressions in contiguous leads. And the T wave is positive, which is always good. In V1, we seem to have this, no P waves are discernible, but we have this Q wave, which is not normal. And then if we look at doesn't look like to be any ST elevation of note. However, when we get to V2, so no real discernible P waves. We have this R wave with this slurred S wave, but as we come here, we see we have almost about 6 millimeters of ST elevation in V2. If we draw a baseline, we're almost a full box and then one little box above. or actually, so if we come up, this is our, see, sometimes that, gotta be careful. So let's zoom in. Something didn't sound right. So baseline, S wave, remember we said that isoelectric point, which is right here. So we have 1, 2, 3 ST elevation. In V3, we have a little bit of ST elevation as well. Again, we have this kind of like wide, odd QRS complex throughout, right? Like it's kind of just widened more than it should be. And no discernible P waves. And these T waves are a little bigger than V6, so we could say we have loss of precordial T wave pattern. So a little bit of ST elevation, a little bit of odd QRS, yes, loss of precordial T waves. These are almost reminiscent of those de-Winter T waves, no? But it seems that there's no ST depression to go along with it. So we have this RS, we have some slurring S. We have that almost hyperacute T waves in V3, V4. V5, we should have a little bit of a Q wave, and we don't. We see a dominant R wave, some S wave slurring. This upwards. So this is ST depression, right? Because if we, so let's zoom in. We have our baseline. Right? Here's our S wave, and here's that isoelectric point. So there's J, we're below the baseline, so we do have some ST depression. Seems to be up at about 0.5 millimeters. So you could argue that V5 has de-Winters. V6. We have that R complex. No real ST depression, and the T wave is upright. So in this 12 lead, it seems that we do have quite a bit of ST elevation in the high laterals, with some, we'll say, something's going on in the regular laterals, the V5, V6. We definitely have some ST depression in the inferiors. And do we have some de-Winters in the V3, V4 range? And we also have a pathologic Q in V1. And overall, we just have some odd QRS complexes. All right. All right, now we're really picking up steam here. So let's go to the lead, or example 9. All right. Do you guys' thing, so pause it and come back when you guys are all done. All right, welcome back. So let's see, what do we have here? So we see that our first pattern is disrupted because we have some profound negativities in the left. We see AVR is not negative. We see that the V1 to V6 pattern is almost reversed. We see that we have some T wave inversions. And what else? Do we see anything with the Q waves? We do see Q waves in V1. It's hard to tell if it's a Q wave in V2. We have no Q waves in V5 and V6, so the quick 5 pattern definitely tells us we need to investigate a little further. Alright, so let's do that. And again, I'm going to be going a little quicker on this one, so I'm just going to be pointing out kind of stream of conscious, the things that I notice. Alright, so kind of hard to discern the P waves. We have this fragmented QRS complex, but our T wave is upright. no ST elevation or ST depression. Lead 2, we have positive P waves. We have this RSS prime complex with maybe a little bit of ST elevation present. And this is a 40-year-old female, so not unreasonable if she were to have Burr, so we'll keep that in mind. We'll do question mark Burr. We have P wave, tiny R wave, odd S wave, and a little bit of ST elevation again. AVR, we have the Q waves as noted, but this time we have a dominant R wave in AVR, which we know is pathologic. And our T wave is inverted, which is reasonable. In AVEL, we have P waves are hard to see, but we have this fragmented QRS complex, and we have a negative T wave, which is not too unsurprising. So we will keep this. AVF, we have this P wave, little R wave, this SS prime, and maybe a little bit of ST elevation. V1, we have this P wave, we have Q waves, which is abnormal, so pathologic Q. We have the bunny ear pattern, right? So the Q, R prime. And we have T wave inversions, which isn't too uncommon in V1. So we definitely know we have pathologic Q waves. And we would say the R prime complex is abnormal. And speaking of which, the dominant R wave in V1 is pathologic. We have a P wave. We have some slurring, so delta wave. Again, we have an R prime complex. Maybe a little bit of ST depression. And we have some T wave inversions in V2. In V3, we have the P wave. We have these kind of, just say fragmented QRS again. STs seem fine. And the T waves are upright. V4, we should be having dominant R waves in these two leads. Right, but instead we have these fragmented QRS complexes. It's hard, it looks like, we'll say question mark ST elevation. And our T waves are upright, as we would enjoy. P waves, upright. We have this RSS prime monstrosity of the QRS complex. So a little bit of a, again, a fragmented QRS. Maybe a little bit of ST elevation, and our T waves are upright. So we have P waves, no Q waves, or that was another thing in lead 5, so Q waves are missing in both V5 and V6. Maybe a little bit of ST elevation, but our T waves are fine, and we again have that fragmented QRS. So quite a few things going on. So in all, we have, again, we have some odd fragmented QRSs. We have some ST elevation. Things that look like Burr. We have dominant R waves in AVR and V1. And we have absent Q waves in V5 to V6. Alright. Alright guys, last example, last but not least. So let's have a look. So we're going to go through this example as if it were, you know, an EKG that someone handed you in the medic unit or in the hospital. So quick look here, everything looks fine. This looks fine. No T-wave inversions, the pattern is good. And I see little Q's, Q's fine, little Q, no Q, no Q, no Q, Q, Q. Alright, so everything in our 5 pattern looks good. Let's go through, and instead of going through the leads one by one, let's go through the leads a little bit more realistically, which is kind of grouped by location. So I always start at 1. 1 is a high lateral along with AVL. And I look to see that the positive P wave, the dominant R wave, the positive T wave, no ST changes, so lead 1 is good. AVL, it's contingent lead, also see some positive Ps, some dominant QS complex, and the T waves are non-discernible, but nothing to write home about. From there, I move down to lead 2, which is the inferior lead, so I look at 2, 3, and AVF. We see tiny Q waves, which is reasonable in the inferior leads. We see what appears to be just a little bit of ST elevation, but it's pretty reminiscent of Burr. And we see small notching, which kind of helps with the confidence of that call. And obviously, if my patient was complaining of chest pain, I would be a little more mindful. In AVR, I'm looking for that dominant R wave. I don't see. I see everything is negative, so I move on. We've already looked at AVL. AVF, we've already looked at because it was a part of that inferior group. So now I look at V1 and V2. I know that the P wave mostly is positive. It can be a little biphasic in V1. I know that it should be a dominant S wave in V1 along with V2, and that I see. I don't see any dominant R waves, no ST elevation noted, no ST depression noted. The T wave in V1 is negative, which is fine. In V2 it's positive. And so V1 and V2, those right ventricular or septal leads, more septal, look good. V3, V4, those anterior leads, I'm looking for a more dominant R wave than S wave, and I see that. I see V3 as the isoelectric point. I see maybe a little bit of ST elevation, but I'm going to call that Burr because it doesn't look like anything anywhere else, and there's no reciprocal changes anywhere else. And it's upward sloping, but we don't know. Right. Same with V4. Then I look for those lateral leads, and I look to make sure that there's tiny Q waves. I see again there's a little bit of Burr action going on. T waves are positive, P waves are present, nothing crazy going on. So all in all, I would say this is a normal sinus rhythm with a little bit of Burr. And that's how quick looking at a 12 lead can be when using this technique. Alright guys, good job. This is a lot. There's a lot of examples, and congratulations if you made it through. I would definitely recommend just going back, letting the information sink in a little bit, and revisiting these examples just to get another look. I would be remiss if I don't point out some resources. So from this point on, I think these resources would be a benefit. So Life in the Fast Lane, which I have to give a special shout out to. They helped me a lot in preparation of this video and a lot in learning 12 leads. And another resource is a book called The ECG for the Emergency Physician. And it's just EKG after EKG after EKG with amazing write-ups in the back of the book by the author. All right, guys. Congratulations. Good job. It's a lot of information. And let it sink in. And when you're ready, I'll meet you over at the third video where we combine these things that are going wrong and we start to put some names on them and we start to see some patterns emerge. All right. Again, thank you for joining. If you have any thoughts, comments, or concerns, feel free to put them down in the comment section. Alright guys, good luck with your studies.